would like to present Professor Dr. Samir Naim, Professor of Endocrinology, Alexandria University. He will talk about thyroid dysfunction in chronic kidney disease. Professor Samir. Professor Samir معانا online. بروفيسور سمير سامعني؟
سامع حضرتك سامعني؟
تمام.
Thank you very much. حضرتك سامعني استاذ منتصر؟
مظبوط تمام.
Okay, thank you very much for a nice introduction from the chairman, Professor Muntasir Zaid, Professor Elbaz. It's really an honor and pleasure to be invited for this distinguished Nefro Alex, and thanks to Professor Salah Naga as well as to Professor Yemen Gohari. And when we speak about thyroid and chronic kidney disease, to me, it comes to my mind always the picture of one of our patients, this lady. And you can never tell whatsoever if this really hypothyroidism or a form of CKD as nephrotic, because she's got puffy face, pale, rough skin, and a little bit blunt. But if you see the full story clinically, you see that this is true hypothyroidism because there is a scar. But this is not the aim of my presentation. The aim of presentation is to link between the thyroid and the kidneys. And I will be speaking about the effect of thyroid dysfunction on the kidneys, the effect on chronic kidney disease, on the thyroid itself, and lastly on common conditions like the use of certain drugs affecting the thyroid as well as the kidneys. We'll start by the effect of the thyroid on the kidneys, and this is from a publication in 2020 from Basu and Mohaptra, and he gathered very interesting data that in hyperthyroidism there is cardiovascular effect in the form of increased heart rate, cardiac contractility, cardiac output, peripheral vascular vasodilatation, and increased renal blood flow with increased beta adrenergic receptors. While in hypothyroidism, there is the reverse. So there is diminished renal blood flow. And if you see the effect of the thyroid hormones on the kidneys itself, you find that with hyperthyroidism, there is increase in the renin-angiotensin system activity, increase in the filtration pressure because of vasodilatation of the afferent and vasoconstriction of the efferent arteriole, leading to increased glomerular filtration rate. This in addition to some increase in the tubular-glomerular feedback due to leading to increased reabsorption of sodium and bicarbonate with increased activity of the sodium-hydrogen exchange activity. While in hypothyroidism, you got the reverse. So you got the increase in the filtration pressure with glomerular filtration rate as well. But both of them have got abnormality in concentrated urine, hyper and hypo as well. Well, clinically speaking, what is the impact of these changes? So in hyperthyroidism, normally you can get low serum creatinine due to low muscle mass and increased GFR, while the serum cystatin, which is now being used as a marker for kidney function, is increased in this patient due to increased cell metabolism. So it's better in these patients to use the NGAL, which is a promising new biomarker for reduced renal function. It seems unchanged by the thyroid status. So in this patient, if you want to follow the kidney, better use the new biomarker. In hyperthyroidism, again, there is increased 24-hour urine protein increase due to glomerular hyperfiltration, and there is diminished ability to concentrate urine. So we are seeing polyuria due to hyperthyroidism without diabetes. And the explanation is that the increase in renal blood flow, osmotic diuresis, as well as reduced aquaporins, which leading to form of nephrogenic DI. On the other hand, with hypothyroidism, you expect the serum creatinine to be elevated due to diminished GFR and the cystatin level to be low. So this is in hypothyroidism. In addition, there is increased glomerular capillary permeability leading to some protein leak. So it is not uncommon to see proteinuria in this patient. And all these changes are corrected whenever you correct or you control the hypothyroidism. Of course, hypothyroidism is famous by hyponatremia, and this is due to diminished GFR, diminished sodium reabsorption in hypothyroidism, the relative increase in the antidiuretic hormone, in addition to the increased sensitivity of the antidiuretic hormone leading to impairment in the water clearance. When you see a cross-sectional studies about a new thyroid patient, about the relation between TSH and GFR, there is usually an inverse relation. So when the TSH is high, the GFR goes down. And these are different trials in new thyroid patients. In this interesting study from Netherlands, they have shown that in a patient with hypothyroidism, the GFR is lower than in patient with hyperthyroidism. This was the cross-sectional part of the trial. And this trial did not include only euthyroid, but it did include hypo and hyper. And so this is expected. In hypothyroidism, the GFR will be low. This is expected. But finding such relation does not show which is first. Is the low GFR causing high TSH, or is the high TSH causing low GFR? So it's important to do prospective follow-up studies. And in these two studies I am showing, these were among euthyroid patients. And they have shown that the risk of chronic kidney disease development within 3 years was significantly higher in patients with high TSH, meaning in patients with hypothyroidism. And another study from Korea did show that. So this is the TSH, high TSH associated with increased risk of having chronic disease. But what about patients with true thyroid dysfunction, with either hypo or hypothyroidism? I'm going back to the Rotterdam study, and this they did show, strange enough, that patients with hypothyroidism, the rate of decline of GFR is less than patients with hyper. So it seems that having hyper is bad for having future kidney disease. And they show the same, the odds for having chronic kidney disease incidence was lower in patients with hypo comparison to patients with hyper. And so the statement was that hypothyroidism is associated with less chronic kidney disease incidence. And another trial from Tennessee, USA, on almost 5,100 patients and 500,000 patients, they did show high PT4 is associated with increased risk. Another paper on 113,000 patients, they did show that the low thyroid function is not associated with the traditional renal function. So it seems that this relation is very interesting. Hypothyroidism, it rather protects the kidney from further deterioration, while PT4 is bad. And this is the explanation that in hyperthyroidism, there is acceleration of the chronic kidney disease by increasing the intraglomerular pressure, by predisposition to proteinuria, increased free radical generation, and increased RAS activity, leading to acceleration of the renal fibrosis. On the other hand, what is the effect of chronic kidney disease itself on the thyroid? And it is a famous knowledge for everyone, for endocrinologists, for nephrologists, that there is increased risk of hypothyroidism in chronic kidney disease. The ratio different from different studies, maybe between 20 and 30%. And in this publication 5 years ago, you can see that for every 10 ml deterioration of GFR, you get increased 80% higher risk of having hypothyroidism. So this had been an old knowledge. But the effect of the chronic disease thyroid profile can be summarized in this cartoon. We find the hypothalamus, there is increased TSH in this patient with abnormal TSH structure, in addition to diminished TSH response to the hypothalamic hormone TRH. While the effect of the thyroid, there is increase in the size of thyroid in patients with chronic kidney disease. You can get nodules. We have done a lot of research on this point. and with diminution of T4 response to TSH. So by the end of the day, you get low T4, free and total T4 synthesis in the thyroid in patient with CKD. What about this in circulation? Circulation, the iodine content is high due to diminished renal iodine excretion. And there is abnormality in the protein binding. So there is diminution of the thyroid binding globulin and in the prealbumin. And this will lead to decrease not only in the total, but also in the free T4 and free T3. In the tissues, there is diminished conversion of the inactive T4 to the active T3. That's why you can get rather relatively high free T4, while the free T3 is usually quite low in the tissues. Lastly, in the kidney, there is abnormality in the TSH clearance. And as I mentioned earlier, there is diminished iodine excretion with increased loss of the binding protein. This will lead to alteration of the level of thyroid hormone, namely diminution in the total T3 and T4, increase in the little bit of increase in the TSH. So this is expected in patients with chronic kidney disease. So what about hypothyroidism in patients with chronic kidney disease? I did mention the incidence is higher than the normal population. In addition, in this Italian study, they showed that even the thyroid autoimmunity is higher in patients with GFR less than 60. And the explanation is not very clear in this. Although in other publications, they showed that there is no increase in the autoimmune thyroid disease in patients with CKD, but still they have a higher incidence of hypothyroidism. And the explanation say that autoimmune thyroid disease can be associated with other autoimmune disease which can affect the kidney, like systemic lupus or type 1 diabetes. And they gave an alarm to the clinician that whenever there is high TSH in association with other autoimmune disease, you have to think about autoimmune hypothyroidism and measure the anti-thyroid antibodies, which are the hallmark for diagnosis autoimmune thyroid disease. And the management strategy of hypothyroidism with chronic kidney disease remains not very clear. I will show you this slide. In this slide, they mentioned that there is the reduction in T3, as I mentioned, reduction in the T4 with elevated TSH. And you expect that to be not euthyroid, because in chronic kidney disease, there is a state called CKD syndrome, in which the T4 and T3 can be low, while the TSH is only mildly elevated. But if you find the TSH higher than 10 or even higher than 20, this will confirm the presence of hypothyroidism. And there have been a lot of debate about treating this patient. Should you treat hypothyroidism patient with CKD or not? I will show you some data. In general, they considered, as I did mention, that if the TSH elevation is mild, less than 10 or less than 20 in some references, with or without low T3 and T4, generally, you do not try to give thyroid hormone. You give only thyroid hormone when the TSH is higher than 10. But I will show you a few slides. This interesting study published 3 years ago, this was done on non-diabetic chronic kidney disease patients, and they gave them thyroxine, small dose, 25 microgram of thyroxine in patients with hypothyroidism, even subclinical hypothyroidism. The TSH was not very much elevated. And look at that. They have noticed there is improvement of GFR with follow-up after 6 months, almost double the baseline. In another study published by Shin and his colleagues, he studied 13 patients with chronic kidney disease, and they have given them thyroxine in small dose in patients with subclinical hypo, and they found that there is the rate of decline in GFR was much attenuated. And they found that giving thyroxine in small dose in patients, even with subclinical hypothyroidism, will lead to decline in stage 5, the progression to stage 5 in 80% of the patient with stage 2 to 4. And the mechanism of improvement, I did mention, is clear, because thyroid hormone will lead to increase in the renal blood flow by increasing nitric activity. It will increase in the cardiovascular effect. and it has a direct effect on the kidney with increase in the renin and increased sodium reabsorption. At the end of the day, there is improvement in GFR by thyroxine hormones. What about treatment of hyperthyroidism in chronic kidney disease? So you've got a patient with hyper, and he is particularly on dialysis. It is a very important clinical tip that we can use antithyroid drugs in patient on dialysis. But if you use carbimazole or methimazole, it is better to use it after the session of dialysis. While the proprietary acid, which is protein bound, can be used independent of dialysis. This is an important clinical tip for clinician treating hyperthyroidism in CKD patients. And if you need to treat this patient with radioactive iodine, you have to be cautious because the dose will be different, as I will tell you in a minute, but also there is increased loss of radioiodine during the hemodialysis, and this will create problem to the environment, loss of radioactive iodine in the hemodialysis session. I will speak shortly about two short conditions, the thyroid in hemodialysis patient, and as in patient with CKD, we expect to have minor increase in TSH with diminution in T4 and T3. And in this condition, we consider that as a physiologic compensation because this will type of adaptation to the new state. There is no real hypothyroidism. But mind you, in dialysis, you use an nephrologen heparin, and this heparin will inhibit the T4 binding. So with heparin use, you can have low total T4 and increased free T4. So you have to watch. If you have the patient on dialysis with high free T4, doesn't mean this is true. No, this is due to heparin. And again, you treat only in this patient if the TSH is quite high, if the TSH above 10 or 20, or if there is associated autoimmune disease evidenced by goiter, evidenced by abnormal antibody, or patient having already thyroidectomy. So in these cases, you have to treat even mild increase in the TSH. You don't have to wait to have a TSH higher than 20 because improvement of GFR will occur by thyroxine treatment. The second effect is renal transplantation of thyroid. Kidney transplantation reverses all the effects I did mention. So the low T3 and T4 and the high TSH, they are correct, but it takes about 3 to 4 months. And the low T3 pre-transplantation had been associated with a high risk of graft loss. But despite of this, giving thyroxine to this patient will not improve the graft survival. So again, you have to remember that you have to follow the rule. If the TSH is higher than 20 or less than that, but in the presence of goiter, autoimmune thyroid disease, or post-thyroidectomy, you are allowed to use thyroxine in small increasing dose. The last part is about condition linking both the thyroid and the kidneys. And the use of drugs is very important. You can have thyroid drugs which affect the kidney. You can have kidney drugs affecting the thyroid, or drugs affecting both the thyroid and kidneys. And I will allude to this table, very interesting table. The cyanamide we are using for the treatment of hypothyroidism, sometimes, although rarely, but you can get glomerulonephritis and vasculitis. The use of alemtuzumab, which is used for induction agent in renal transplantation, can lead to autoimmune thyroiditis. Interferon alpha used for treatment of hepatitis B or C pre-transplantation, and even used for the treatment of renal cell carcinoma, can lead to transient hyperthyroidism. Lenalidomide, used again for renal cell carcinoma, can lead to subacute thyroiditis with transient hyperthyroidism. The famous sunitinib, target therapy or using it for treatment of renal cell carcinoma, is famous to be associated with hypothyroidism. Lithium for bipolar depression can lead to both hypothyroidism and affection of the kidney. Of course, I did mention the use of iodine. If you want to use it for Graves' disease or for treatment of thyroid cancer, you have to remember that you need to reduce the dose in patients with CKD, particularly on prenatal dialysis, because the excretion of iodine is diminished. So you have dose reduction in these patients. So at the end, Mr. Chairman, ladies and gentlemen, allow me to conclude by saying that the relation of the thyroid and kidney is two-way relation. By hypothyroidism, you get alteration in the different kidney profile with diminished tubular mass, diminished cardiac output, intrarenal vasoconstriction, diminished RAS activity, diminished tubular glomerular feedback, some glomerular-based membrane, leading to deterioration of kidney function, and these usually are reversed by treating hypothyroidism. On the other hand, chronic kidney disease can be associated with non-thyroid illness, a little bit elevation of TSH and low T3 and T4, and you can lose the thyroid hormone in peritoneal loss and in nephrotic, and this has an important clinical implication because this patient, you need to give them extra dose of thyroxine if they are treatment of thyroxine. Again, the kidney disease can be associated with true hypothyroidism due to iodine excess or selenium deficiency, or this selenium is not very clear because a recent publication showed that oral selenium supplementation did not have significant effect on thyroxine in patients with hemodialysis. At the end, Mr. Chairman, ladies and gentlemen, I will end by this slide. And this shows that the mortality in this big number, about 250,000 in US veterans, patients with stage 3 chronic disease, you can see that in non-dialysis dependent chronic kidney disease, the mortality is higher if you have high TSH, I mean hypothyroidism, or if you have low TSH. So this type of U curve is very important. So in both hyper or hypothyroidism, when they go into chronic disease, mortality is high. So you have to be watchful. You have to treat these patients very, very carefully. And thank you very much for your attention.
Thank you, Professor Samir, for your elegant presentation about thyroid and chronic kidney disease. Any questions for Professor Samir? أستاذ طارق تحب تضيف أي حاجة؟ Would you like to add any comment?
Professor Tariq, can you open the mic, please?
Dr.
I'm
Mohammed
sorry, I've
Saeed.
been talking to myself. Yes, I'm sorry. It was a very comprehensive talk, Professor Samir, and it really shows how complex the situation is. We better refer thyroid patients to endocrinologists yourself instead of trying to treat them. That's my conclusion.
Oh, thank you.
Professor Saeed.
Thank you, Professor Samir, for this elegant presentation. What I would like to comment, your last slide, the mortality that has been associated with low T3 and low T4. Do you think it is a causal relationship, or the low T3 and T4 might be an indirect footprint for other disease, or there is other players in the scene presented with low T3 and T4 directly related to the mortality, not a direct causal relationship between the low T3, low T4 and mortality?
Yeah, very good question. Very good question. And you see that in this type of epidemiologic study, they don't show the cause. They tell you that if you have high TSH, I mean, as index of hypothyroidism, there is increased mortality. If you have low TSH, this means mostly hyperthyroidism, there is high mortality as well. This shows you which is first. Is it the egg or the hen? It's first. But as I did show early, that in patient normally with even hyperthyroidism or hypothyroidism, there is alteration in the kidney. So this is showing that the effect of thyroid is probably the first. But also don't forget that the kidney itself is associated with some hormonal problems. But I would go for me as endocrinologist, maybe I am biased that it is a story of thyroid first rather than the kidney. Thank you very much.
Professor Salah.
شكرا دكتور سمير على المحاضرة القيمة دي، واحنا نتشرف بوجودك معانا في نفرو أليكس، وإن شاء الله نشوفك تاني وتالت إن شاء الله.
شكرا جزيلا، انا متشكر جدا.
في حاجه غريبه هي كلينيكالي، احنا دايما بنشوف اكتر الهايبوثايرويد اللي بيجوا لنا اصلا بيبقوا جايين على اساس ان هم سسبكتد نفروتيك، معاهم شويه بروتونوريا، معاهم شويه رينال امبيرمنت، وبنقيس التي 3 والتي 4 زي ما وريت في الصوره، بنلاقيهم واطيين وبنديهم
تريتمنت
الريبليسمنت، وبعد كده الكدني
يتحسنوا.
ايوه مخالف للي انت بتقول ان هم الهايبوثايرويد، يعني دايما الهايبرثايرويد هم اللي بيديتيريوريت اكتر.
لا يعني النقطة ان انا قلت في السلايد ان هي في الهايبوثايروديزم بيحصل تشينجز في الكدني دي ريفرسبل، البروتينيوريا والانكريز جي اف ار، او ما بنصلح الثايروكسين دي امبروف، انا قلتها في اوائل السلايد. لكن الجزء الثاني ان هم قالوا الناس اللي عندهم هايبوثايروديزم وتابعوا الكدني فانكشن اون ذا لونج تيرم، يعني هايبوثايروديزم، لقوا ان الديتيريوريشن اوف كدني فانكشن فيهم اقل. ده غير النقطه ان سيفير ان كنترول، زي ما حضرتك بتقول، هو بيجي لحضرتك ان هو متشخص نفروتيك في بروتينيوريا وجي اف ار قليل والباديوريا عاليه، حضرتك تشك تعمله تي 4 تلاقيه في الارض والتي اس اتش في السماء، يبقى ده تيبيكال هايبوثايروديزم. اول ما حضرتك بتعالجه او تبعته لنا نعالجه بيتحسنوا على طول الديتوريشن دي، واحنا دي بنشوفها في حاجات كتير اوتو اميون، فدي يعني الاثنين ما فيش منهم تضاد قوي، فدي ملحوظه مهمه جدا من حضرتك قلتها. This is a lesson for the junior. الملحوظه اللي قالها الاستاذ الدكتور صلاح نجا، ملحوظه مش اي عيان يجي لك ببروتينيوريا ومنظر كده بليز اطلب له تي 4 وتي اس اتش. شكرا جزيلا.
هي الحاجه الثانيه اللي هو الهايبرثايرويد، احنا من نادر ان احنا نشوف هايبرثايرويد with progression to CKD to stage 5.
لا هم الستاديز اللي انا وريتها هم دي كان statistical studies، ان هو حطوا الاكسبلانيشن ليه ممكن يحصل further، لكن الهايبرثايروديزم بير سي ما لا تؤدي زي ما حضرتك قلت. ما احنا بيجينا عيانين هايبرثايروديزم نادرا لما بنلاقي عندهم abnormality، ليه؟ لان الجي اف ار بيتحسن، لكن لقوا ان هم دول on the long term في الستاديز اللي قالها بعد 10 20 سنه الابيلتي تو هاف كرونيك كيدني ديزيز از لو، وحطوا اكسبلانيشن اللي انا قلتها في الاول. لكن كلينيكال سبيكينج حضرتك عندك حاجه تماما، عيانين الهايبرثايروديزم عكس الهايبو ما بيجولناش برينال افكشن ولا كلينيكالي ولا لابوراتوري.
بنشكر الاستاذ الدكتور سمير for his
أنا بشكركم جدا.
presentation and nice comments and answers. شكرا. I would like to thank my colleague Professor Dr. Tara Elbaz co-chairing me this session, and it's time to close this session. Thank you.
طارق انت معانا يا طارق؟
لا لسه موجود.
Tara, you will continue. You
Yes.
will continue. You are a chairperson in this plenary lecture.
Right.
شكرا أستاذ سمير.
شكرا جزيلا.